All right, it seems to have slowed down. So again, thank you everybody. My name is Melinda Southard. I'm the Deputy Director for the Nevada Health Authority for Community Supports and Workforce Development. And just wanted to welcome you all to today's Stakeholder Update Workshop. Really appreciate you all making the time to attend today. Just for your information, today's meeting is being recorded. We will be posting the recording on our YouTube channel later this week, and we will also be posting a copy of the presentation slides to our public notices meeting webpage rather shortly. So with that, I am going to hand the presentation over to our director, Stacy Weeks, to go ahead and get us started.
Thanks, Melinda. Good afternoon. Hopefully, Melinda, can you guys hear me okay, since I've had some issues today? Okay, cool. If you can't hear me, Melinda, just jump in. All right. Well, welcome everyone. Thank you for joining us on a Monday afternoon in the middle of summer. We'll just dive in. Next slide, please. Oops. There we go. All right. So today we are excited to get together with everyone to give an update especially after session. On the Nevada Health Authority rollout, there's some federal legislative updates this summer that we have, as well as a status update of all the projects underway at the Nevada Health Authority. In addition to, at the very end, we do want to just remind folks about some other upcoming stakeholder activities that we have. And then just to gather feedback and answers and questions and provide answers from all of you. So please don't be shy at the end. Chime in or put questions in the chat as we go along, and we can answer those at the end. So next slide, please. All right, so July 1, we officially launched. We're calling it the Y2K, right? We were all super excited about what was coming, and then we weren't sure what was going to happen on July 1, and it was business as usual, but just a bigger team. So we're super excited about this launch, and we are definitely busy. It's 28 days, and we are already moving forward pretty quickly. Next slide, please. Reminder from session, for those of you maybe who did not follow the session, the why behind the Nevada Health Authority is really to capitalize on, as the governor said, to capitalize on the broad and strong purchasing power of the state. And then a lot of times that's Medicaid, as we do contract at Medicaid for billions of dollars in the healthcare system. And so as we are purchasing, a lot of what we do in healthcare and our coverage programs, or even offering access to, example, the subsidies to the exchange, it's really a mechanism for purchasing for the state. And so it's really leveraging that power in one entity to get a better deal for taxpayers. But it's also creating new efficiencies and how we do our work as healthcare entities. We'll talk about it in a minute, but we do have all of the state healthcare programs under one umbrella now, and we can really harness all of the work that we're all doing and making sure that we're running together and doing it faster together. But we've outlined a vision and a mission, as you can see, and our vision is a healthy, thriving Nevada where healthcare is affordable and reliable for all. And our mission is obviously to ensure that Nevadans have access to this reliable and affordable care by leveraging our state buying power, streamlining our programs so it's easier for people to access and understand, and our providers, and driving better quality and more innovation in our healthcare system. Our values are really staying true to public service and really what goes along with public service. And that integrity, and as well as fiscal discipline and accountable leadership in this work. Next slide. All right, so what's changed? Someone asked me the other day, is it just a name change? And I wish it was that simple. It is not. It's a pretty massive change. The good news is I hope a lot of the folks that work for us don't feel that way. I hope that they feel like the work continues and that there is not a beat, a miss in that beat every day that we have the work that we're doing. But then as we work together now, as all of us together under one umbrella, that we are moving forward together in healthcare. So generally speaking, from a public perspective, I wanted to give you guys a visual of kind of maybe what I would think from the public coming to the health authority. So what's changed? So we have Medicaid today under the Nevada Health Authority. Previously, it was under Department of Health and Human Services, which was divided into two agencies. So Medicaid is now over in the Nevada Health Authority, and now we have the Department of Human Services. We did move eligibility policy, which used to live under the formerly known as DWIS agency, which is Division of Social Services today. Eligibility policy moved under Medicaid. So Medicaid does make the decisions around what do the rules mean? And then our Division of Social Services helps us implement that in the community in terms of eligibility and enrollment. We are working on doing a new, more of faster enrollment process through the exchange, but that will take some time to lift. And it won't always serve everyone. There are still individuals that need Medicaid or eligible for Medicaid that will still need high touch that can't just go through an online system, right? So there will still be a need for that other piece too. Also, the exchange is now part of the Nevada Health Authority family, if you want to look at it that way. The marketplace has come over as part of our work in accessing, helping people get better access to healthcare coverage and really focusing in on that health literacy of like when you get health insurance, what do you use for it? How do you use it, right? So that's something else we want to work on more broadly at the Nevada Health Authority. And then PEB, our Public Employee Benefits Program, is now under the same umbrella. And our Battle-Born State Plans, which is, as some may know, as the public option, which will be live this next year in the exchange. And then our facility licensure, which is also known as Healthcare Quality and Compliance, which is ACQC. Our facility licensure used to live under Division of Public and Behavioral Health under the formerly known Department of Health and Human Services. So that piece came over as well. And that's part of our work in really ensuring that we have quality care and quality hospital care and quality facility care statewide. Next slide, please. All right. Another fun way someone told me the other day is it just moving all the chess pieces, right? And it's nothing more. And I'd like to think of it as we're moving the chess pieces to win, right? And we're doing it in a way for the first time where, hey, we got a better hand, right? That we're playing and that we actually can win under this new board that we've designed. So we're really working together, like I mentioned earlier, to streamline our programs, look for efficiencies. Where can we in Medicaid support PAB and the exchange and vice versa? Also better leveraging our purchasing power, which we're working on a state purchasing strategy, which I know some folks will talk about later. And we're also focusing in on ensuring that we have an open door for Nevadans who are eligible to access low cost or no cost healthcare coverage options. And then also last but not least, but build a future, like kind of one of my dreams is to have a one-stop shop for providers where they can get credentialed, licensed, contract, enroll into our programs and really experience the same experience across all these markets. So prior authorizations would be the same across these markets, all the things, all the forms, so we can really streamline. So that is sort of a bigger dream, but this is really helping bring that together. Next slide, please. Whoop. Okay, thanks. Thanks, Alinda. So this is our team. I know some of them you have seen many times before, and there are a few new faces. But we have Sandy is our new, she's doing the new Chief Enterprise IT Officer. So in our director's office is the first four boxes there you'll see are our director's office. So you have Sandy. We do have a chief of staff, which hopefully this person, once we find the right person, will be able to start later this fall. And then Lynette Aaron, she is our Deputy of Healthcare Financing and Budgets. And then Melinda Southard, who is our Deputy of Community Engagement, as well as our Workforce Development and Healthcare. This is our director's office. And then below that, we have our four divisions. So we have Todd Rich, he is our new administrator over healthcare purchasing compliance. Jennifer Krupp, she is our administrator over consumer health services. This is where our exchange lives, as well as the Battle-Born plan and Medicaid eligibility. Todd, I forgot to mention, is over, and there are better slides later to really show this, so don't have to write down. But Todd is over licensing, so HCQC, as well as our Medicaid Inspector General unit and provider enrollment and centralized credentialing, as well as our purchasing and contracting unit and compliance. Nick Proper is over, he's our interim executive officer over at PEB. And then Ann Jensen is our new administrator for Medicaid. Next slide, please. All right, so we decided to go ahead and set our goals for the next 3 years and really think through, and we're obviously looking for feedback on these, but we've been trying to think about how do we achieve our mission, right? And not for just be a mission on the website, that we're actually on a mission to get somewhere. And so the first thing here is really looking, as I think we all know, nationally, Nevada ranks in the bottom 10. I think we're 51st right now in maternal health, for example. Mental health, we're at the bottom as well, across the board, even on quality and safety at the hospital side. So what can we do as a state to get out of those national bottom rankings, right? So how can we improve on key health indicators? So it's one thing we're looking to build out. And what does that mean? So obviously we will be looking at more of a strategic business plan for the agency for the next 3 years. And we will be bringing that to the public, hopefully early next year for feedback and just to really present to everyone what we're working on. We're also working on increasing the sustainability or strengthening the sustainability of our coverage programs. And this is really looking at that budget side, right? Like we want to do good healthcare, but we can't just spend money, spend money, spend money, and not know how we're going to sustain it, right? So how are we sustaining these coverage programs? Is it bending the cost curve? How are we doing that? Is it looking at better ways of paying for healthcare, like value-based payment design? What are we doing? Or even leveraging purchasing power, for example. What are we doing to control costs so we can maintain these programs long term? Third is expanding the capacity of our healthcare workforce to meet the needs. As my former director, Richard Whitley, used to say, if you have health insurance, it doesn't mean you have healthcare, right? And he's so correct. It still is because, we can do this all day, but people can't access providers. Having coverage doesn't matter. And so we really need to get at this piece. As we know in Nevada, we have a real problem in ensuring we have enough providers to serve our population. And then last but not least is driving better value, coordination, and innovation in our healthcare system in Nevada. And on the side here are just some of our guideposts for the work and the things that we feel we hold true to the work that we do. I already talked a lot about these earlier, but really that efficiency one is something we're looking at early on in this work. And then as we move forward, obviously, we'll be thinking about that better value with our strategy around purchasing. Next slide. Melinda, I think it's still me, right?
Yes, it is.
Okay, just making sure. Can you hear me okay, Melinda?
Yes,
Is
yes.
it working? Okay. Okay. Next slide. All right. So we have some recent federal changes. It's honestly pretty rare to see federal law change. So, so on July 3rd, Congress passed HR 1, the One Big Beautiful Bill Act. We're referring it to as the OBBBA. President Trump signed this on July 4th. And this bill made several major changes to a lot of things nationally, especially any kind of safety net or programs, but especially Medicare and Medicaid and our state and federal marketplaces. So we're going to walk through some of these high level. I'm going to try to keep them very high level, and there will be more meetings about these going forward. So let's talk first about Medicaid. There are a lot of changes in the bill around Medicaid. Now, I want to just say that when we first presented some of this to the legislature early on, during session, we were looking at a lot of other things that could be on the table. So some of our findings now look a lot different because a lot of those things didn't make it into the final package. So that's the good news. So we'll start with, I'd like to always think about being a little positive first, which is we did dodge a bullet in the sense of we didn't lose our 90% federal funds for the expansion adult population, which is a huge win for us because that would have been a devastating budget shortfall, huge for the state. So I just want to start out by saying that is not on this list, and that is good. There are things on this list that we are still waiting for federal guidance, which really will determine how many of these things will look for the state. So I do want to start out with saying that to you. So let's look at what they are. The first one, I think a lot of you have heard all of these. There are more in the bill, but I only listed the ones I felt were pretty big impacts, but also we could easily talk about today. The first one is work requirements for adults without children. I keep hearing everyone thinks work requirements applies to everyone. I just want everyone to know it only applies to one population type in Medicaid, and that's adults without children. Now, adults without children make up nearly half of our program. But we anticipate about 100,000 people will be initially impacted and could lose their coverage or come back on, right, if they can find employment or get us the right paperwork. So that is the first change that's coming. And there is a timeline. We'll go walking through that in a minute. The second change is there for this population again, we're going to be renewing their coverage more frequently. Now, the devil's in the details always about what the federal government thinks this looks like and what this needs to be, but also how we implement that, right? How hard we make it for people, how hard it is for us and Division of Social Services or the exchange and however we implement these things. So these are the things that we'll be working on going forward. New cost sharing requirements for adults without children. That's on there twice. I don't know why. But maybe because it's a double whammy because it's a lot of work, right? I think is something we need to think about how we do it and what it means and who's collecting that, right, at the provider level. So that there's more to come on that. And I just want to say on these first three that we're talking about, we will have public stakeholder processes to really ensure that we are hearing from everyone about what this means and how best we can implement it. There are changes to retroactive coverage. There is a new freeze on provider taxes or a moratorium in many ways used to draw down. These are what we use today as a portion of what we call state share to pay for the cost of Medicaid. So freezing provider taxes means it limits our ability to diversify our revenue, right? And that can be challenging because that means we got to rely back on the state general fund, which means we're competing against education and all the other programs for healthcare funding. We also use that money to draw down Medicaid match. And so we can still have a provider tax, for example, in this state, but we could never take that revenue and match it with federal Medicaid funds. And that really begs the question, then why do it, right? Because that was the whole point, was to be able to leverage that funding so we could get match. The next thing here is reduction in provider tax rate maximum. This has a similar effect, right? It really is getting at limiting our ability to use revenue. So it's limiting the amount we can collect for existing provider taxes that we have. And then it also lowers the cap on what we call state directed payments. Essentially, these are our way of supplementing rates in managed care. For hospitals is a good example. And it really limits our ability to go up to what we would have paid otherwise if we'd have been in the average commercial market, if we were a private insurer, for example. This says you can't pay more than managed care rates, is what the bill says, and how they implement that is still, a question mark. So the reason you see here the asterisks here is because the skilled nursing facilities are exempted from these requirements. So that's important to note that they're not affected by these changes. In Nevada, it really primarily affects our hospitals, all of our private hospitals. And when we look at the numbers, we'll talk a little bit about it then, but there are a lot of things that we don't know yet. So the numbers you'll see today are guesstimates, and that is the best we can do. I would also just point out that we did have an ambulance tax pass, right, during session that we're going to use to help match Medicaid money and do a rate increase. We were able to put out public notice in time that we think before the bill was passed and signed. So we think we technically have authority to keep that program and keep implementing it. So we'll see how that goes. But right now we're assuming it stays in place. Last but not least is one other issue that's come up is the prohibition on certain Medicaid payments to Planned Parenthood or facilities that conduct abortions. So we are currently looking at how that requirement actually will be applied. There's litigation in this space. So right now this is not moving forward until we hear where the courts land on this issue. Next slide, please. So real quick, and I know there's some slides on the Nevada Health Link, so I'm not going to go into all of it, but I did want to mention the things that are impacting our marketplaces, including ours in Nevada. And just a reminder, the marketplaces are ACA exchanges where people can go who buy their own health insurance and shop for healthcare and get determined eligible for premium tax credits, which they buy down their premiums based on how much they earn and their income. So there's new eligibility restrictions around immigrants and their ability to draw down and use premium tax credits. There's also new limits on certain non-citizens' access to marketplace. It did not extend, and I mean, this was already going to happen regardless of this bill, but I think there was some discussion at some point about maybe extending what we like to refer to as the ARPA federal premium tax credits, but it's really these enhanced federal funds that came into states to help buy down premiums even more. They were going away regardless, but right now we're hearing, I did hear they might be back on the table. I don't know. Someone mentioned this the other day. So who knows? But if they do come back, that would be really great for our market because they really did help relieve some premium increases. But right now in that bill, they were not extended. There's also elimination of coverage for DACA immigrants. that the exchange will give updates on later. New limits on eligibility for federal premium tax credits and subsidies if the individual was deemed ineligible for Medicaid due to not meeting the work requirements. I will say this one is, in my opinion, concerning, right? Because it's a little hard for someone who doesn't have a job to be able to afford private insurance, health insurance. So this is a population I think we're going to have to work closely together with the exchange and our provider community to help people get access to what they need to get health insurance. So if they're eligible for an exemption from work requirements, we need to be figuring that out together. Or if they're deemed ineligible for Medicaid and they're not eligible for an exemption, how are we helping them get a job? And where are we connecting them to our state resources and local resources to do that? So this is something I think we'll see a lot of community work around in the future. Next slide. All right. I think if you push the button one more time, something fun pops up. I did a little animation. Can you push it one more time, Melinda? Yay. Okay. So there's a lot here. And so I wanted just to focus in on a couple things. The first thing here, as you can see, there's a lot of stuff happening. And so these are all will be available so you can look more closely. But I think a big one to point out is the community engagement, or what we call work requirements, are not happening until close to January 1, 2027. Now, states do have option to look what we call kind of a waiver and extension. And I think we are definitely looking at our options, because what we don't want to do is develop something that's not ready for prime time, but we also want to make sure that the Medicaid Express work is aligned with this work. So we're definitely going to be working on that from the eligibility policy side and working with CMS closely. We'll have more to come on that in the future. All right, Melinda, can you push it again? Let's see what other box pops up. Oh, so also one thing to mention, Melinda will be talking about it here soon, is our rural health transformation grants. It's our understanding from the governor's office that we will be responsible for coming up with the grant application. We have been already talking about what in the world this will look like. As you guys may know, it's due like tomorrow, December 31st, 2025, which, if anyone has ever put together a federal grant and knows the process, like we should have had guidance like 6 or 9 months ago, right? So CMS is probably having the same moment we are, trying to figure out what in the world we're doing. But we will be having more stakeholder process going forward, and Melinda will be leading that. So just wanted to flag that we are aware of it, we're on it. We're doing our best to get as much guidance and support. We're also working with Mercer on this. So more to come in that space. And one more time, Melinda. I think there's one more. Oh, okay. Um, Push it again, Melinda. Sorry. There you go. So there's one here I wanted to flag, is that the provider tax hold harmless piece. Like a lot of the provider tax stuff, even though it does have a pretty big impact, and we'll look at the numbers here in a second, to our hospital tax program, it doesn't start until 2028. So there's a lot, I think, in this biennium that we won't see until the next biennium. So it's also an important piece of the conversation. So a big one will be when we start to see that rate phase down of how much we can collect in the hospital tax program, which does impact our children's behavioral health care program that we are working on now. Next. Oh, there's one more. And then obviously cost sharing requirements will begin as well. So as you can see, while these are all very big changes in terms of eligibility and also provider tax programs and payments, a lot of it is not until several years from now. So we do have, the good news is we have time to implement it, but as you guys know in healthcare, 12 months is not very long in implementing anything. So even just having even 2 years is better than one. Next slide. All right, one more. All right, so the big one here I wanted to flag is just that expiration. This is the ACA timeline. We know these are coming. We've known about this for some time, but if they're going to pass something to fix that, they better pass it very soon. So, because exchanges will be in open enrollment very soon. Next slide. All right, so I tried last night to think about how best to explain this. So before we dive into the numbers, I wanted to back up and think through what impacts from a state budget perspective. We're not going to talk about, there is an economic piece of this, right? There's a healthcare system piece of this, but I want to talk today about what is our fiscal estimate for the state budget. So when we think about the state budget, when it comes to healthcare, especially Medicaid, there are four big pieces. And the first one is the federal share. So how much the feds pay the portion of Nevada's costs for Medicaid. The second one is how much federal funds we can get So that's another piece. Those two are very related, but they're also two different impacts in many ways. And when you look at the budget, then there's state revenues. So how much can we collect and spend? And then there's how much is our share that we have to pay, regardless of what we have in the bank, right? So when we look at what passed, and when it comes to federal share, let's start there. That has increased for our state. And the reason that is because work requirements on adults without children. I know that probably doesn't make any sense, right? But this is the population that gets our 90% federal fund. So for every $1 that we spend, we get to draw down $9 to support the cost of this program. The other piece is yes, these individuals are not enrolled, so they should save us money. But the difference here is because the 90/10 supported what we call a blended FMAP. And so for example, our supplemental payment programs, we get to draw more federal funds when we serve more of the 90/10. So it really just changes that federal share portion for the whole program. It just means we got less of the 90/10, even though they don't cost us anymore. It affects so overall when we're able to have a blended FMAP and we're drawing down payments in that way. And so that is an important element that we did include in our analysis. Federal funds were reduced. And this has to do with a lot of things, including the work requirements in many ways. But when I think of federal funds, I'm thinking about our ability to leverage federal dollars. The big one here would be the new cap on state directed payments. And really that cap is really saying it lowers it from average commercial rate to Medicare rate, which is lower. Medicare is higher than Medicaid, right? So there's like average commercial rate, Medicare, Medicaid. Now that we're at Medicare, we're not really maximizing or taking those tax revenues and drawing down as much federal funds. We can only draw up to a certain amount now, and it's lower. So that really lowers the amount of federal funds, and it's a big portion of the federal fund loss is the supplemental payments for hospitals that we are not able to maximize. State revenues were reduced. The big one is taking provider taxes off the table for states, right? In our state, it's a big one. We just implemented our hospital tax 2 years ago. We moved forward in many ways. All those gains are something we're looking at. How do we not lose those gains and what can we do around that? So, hold on just a second. Let me turn off something. Make sure I'm on. Sorry, I keep getting beeps coming through and it's driving me nuts. There we go. And then state shares increase. So our state, the loss of the 90/10 that I talked about has the reverse impact. Our state shares increase for the whole program. But again, it's mostly when we look at any of our payments or any of our programs that are based on that blended FMAP, where when we have more of the adults without children as part of the population, we're able to draw down more federal funds for the larger supplemental payments. So it does impact the larger pie. Next slide. All right. So as I mentioned, again, I'm just going to say this over and over. These are early estimates. I wouldn't even say like they're fiscal estimates or just early estimates, right? They're the best we have based on limited knowledge we don't have guidance. So federal guidance is really going to really tell us whether or not we were shooting the dart and we really hit the hit the bullseye or not, right? For this fiscal year 26-27, regardless of the guidance, I really don't believe we're going to see a big impact because of all those effective dates were pushed out for the big pieces that impact funding. So right now we're looking at some changes, but not very significant. 28-29, there is a pretty, it's 58.5 million. And for state in Nevada, that's money, right? We all know even getting 5 million in a session for something is a lot, right? So this is funding we will definitely have to think about over the next biennium. I want to just walk through some of the assumptions we made that really laid out these numbers, right? Like I mentioned, these assumptions will change or could change with federal guidance. So the first one here is we are assuming about 100,000 or a little more are going to lose coverage. But the cost associated with this directly to our spending account would be that we do assume some of these individuals today are actually people who would normally have only had one option, right? Is go the disability route. And it's not to say they weren't disabled or they are, right? It's about the fact that people that take the disability route are stuck under a lower income threshold, meaning they can't earn more money. They can't work usually because or get certain type of job because if they earn too much money, they lose their access to certain services. For some people, that is the only option because disability Medicaid offers more coverage options. They have different services, more intensive care in the home. Some people have disabilities, but don't necessarily need all of those services and also have a higher income and want to work. And so, or can work, right? All those things. And so a lot we saw when the ACA passed, and then there are studies on this too, but a lot of individuals, we saw people migrating over to regular Medicaid. And that the good news there was we get the 90/10, right? And it's a less costly program. We will see some people we anticipate still saying, I can't lose my Medicaid. I do have a disability, but now I have to lower my income and go the disability route. We do assume a certain population does that. We'll release more details when we're having another look at our analysis too. But right now we're anticipating that's about 3.5 million for the next biennium. That there is some cost here associated with people still needing Medicaid and their disability. They're just going to have to go through the SSI route. The second assumption we made is that the hospital provider tax revenue will be reduced. That I think that is a fair assumption, resulting in less to spend on children's behavioral health, right? Because as you may know, we take 15% of the hospital tax revenue today annually and have it put back in a special account or category for children's behavioral health. We do believe that will be reduced. The impact of that, we are estimating about 25 million for that whole biennium. We do believe that ongoing, if the provider tax stays in place, we will have a roughly around 40 to 50 million still in that count. So the good news is we're not going to be empty in the tank, but it will be less to play with. And so that is an important piece here is we're going to have to do some thinking about what can be spent out of this fund that we know we can control the spending so we don't go over budget. The third assumption is that there will be lower Medicaid managed care expenditures in terms of the amount that they spend or we spend in the managed care space. And managed care is primarily, especially starting January 1, going to be the majority of our program. And the reason this matters in Nevada is we tax those expenditures. And we tax them, I think it's 3.5% premium tax, right? On those expenditures. We collect that tax. Sometimes we match it, but that tax goes to the state general fund. It is a revenue source for our regular state general fund. So we do believe that that will be lower due to state directed payments that get taxed as part of this managed care spend, which is going to be going down significantly. And we do believe work requirements will lower, we'll have lower enrollment than we anticipated. So we think that's about $30 million in the next biennium. Now, this again is something where we are still playing around with some assumptions. We have another actuary also looking at this, but this is where we're at right now as a fair guess of what we're looking at. Next slide. So private hospitals, I did want to talk about the impact because for the private hospitals, we have about 45 in the state. It is a significant amount of money. And again, 2 years ago, we didn't have this investment, but we do today thanks to the provider tax program. So it will be reduced significantly under the bill over the next 5 years. We do not believe that impact this biennium will be felt by very many hospitals. The next biennium, we do believe it will look different. There should be, a lot of things, unknowns are happening here. One is the Medicare rate limit I told you about. We can't supplement managed care claims as much with that money. So what does that look like? And we won't know until we see federal guidance. So the reason there's a range is because we have one actuary saying 600 million and we have another saying 800 million. And it's a lot of it is the difference is how we're assuming Medicare rates, really what that means in the context of the cap. So that is really the big kicker here. So that guidance will be really important. And also a big piece that we don't know is like, how does OBBBA impact all of the taxable hospital revenues? And so that is something too, that's an economic analysis and there's some other assumptions need to be made here. So until we get some more even national studies going on, as well as federal guidance, this is the range that we're using to understand. This is the potential we think the losses will be for hospitals statewide. Next slide. All right, Melinda, I think, is it you?
Not quite yet. I will start at the GME slide. So we'll go to the next one here.
Oh, that's right. Sorry.
Okay.
So we're going to talk real quickly about the director's office. So what we're going to do first is we're going to go through all of our project updates, and we're going to do it by basically our office or division. So we'll start with the director's office. And I wanted to do a quick high level. So as I mentioned, we have our chief of staff, which is over human HR, communications, our workforce development. I'm sorry, that actually should be under Melinda. My apologies, Melinda. Also, office management and any of our legislative work is going to be here, and just some of that bigger coordination in projects across agencies and interagency. And then Sandy, as I mentioned earlier, is our IT and innovations officer. She's also over our Office of Analytics and APCD, so our All Payers Claims Database, and she still maintains oversight of the Medicaid fiscal agent. And then Melinda is over a provider, which is the Healthcare Workforce Development, GME Advisory Committee, Community Engagement, a lot of our committees, our advisory committees and commissions, as well as our Governor's Developmental Disabilities Council. And then Lynette Aaron is over our Medicaid budget, ACQC, and PPC budget are actually still are going to be part of our larger budget at the department level. Supplemental payments will also be at the director's office level, provider taxes, and federal resource maximization. So we can look at leveraging federal resources legally, but efficiently across our agency. Next slide.
Okay, this one's my slide.
All right, thanks, Melinda.
Thank you, Stacy. All right. So hello, everyone. I wanted to talk to you a little bit about the Rural Transformation Grant. Again, my name is Melinda Southard, a Deputy Director for Community Engagement and Workforce Development. So the Rural Transformation Grant, we don't have a lot of guidance on it, but we do have some from the bill itself. So we understand that with this grant, there's no match requirement, which is kind of a big deal when it comes to federal grants. So that's a good thing. We also know that it is a one-time application process, meaning that we have one shot to apply for these funds. And if we're not approved, then we don't get to have access to these funds. So it's a really big deal for us to, engage with our stakeholders and develop a really thoughtful application speaking to all the requirements. And so we are going to, have some more information about public input and how you all can engage with us in this process. As soon as we learn more, we do expect guidance from CMS any day now, but of course they still haven't released it. So the bill itself says that CMS has to both release the guidance for the application and approve or deny all the applications by December 31st of this year. So I would anticipate that they're going to release the guidance sooner than they have to make the decision for approval or denial. Again, we also listed the eligible providers under this program here. So as you can see, it is all of our rural healthcare stakeholders. So really looking forward to working with you all on this grant application and grant program as we do get approved. So sending the good vibes into the future. All right, and then next, I wanted to talk to you about the Advisory Council on Graduate Medical Education. So this is another area that has come under the umbrella of the new Nevada Health Authority. Here I've listed all of the council members. So as you can see, it has a range and there's a variety of subject matter expertise on the council. The council itself has not met formally since 2019. And so we're really excited to get a formal kickoff with all the advisory council members in the beginning of October. So I think we're shooting for October 1st for that meeting. So really excited for that. We do intend to establish a regular meeting cadence with the advisory council. We will be establishing a new council charter and bylaws to really form the governance structure of the council and the intent moving forward. We will be establishing a new website also for the council itself and for the associated graduate medical education grant program. And then lastly, we are looking to develop a formal work plan and a timeline for the council to make those recommendations for the grant funding distributions, of course, in accordance with state law. So with that, I'm going to pass it over to Catherine to talk about the Nevada Governor's Council on Developmental Disabilities. So Catherine, please take it away.
Thank you, Melinda. Hi, everybody. My name is Catherine Nielsen, and I'm the Executive Director over here at the Nevada Governor's Council on Developmental Disabilities. I'll give you just a little bit of brief information about our council and our purpose over here at the Nevada Health Authority. We have been established under the Developmental Disabilities and Bill of Rights Act, better known as the DD Act, and through NRS 232.320. Our goal is to advance advocacy through policy, capacity building, and systemic change activities that promote equal opportunity, self-determination, and community inclusion. The Nevada Health Authority is our designated state agency. However, we are primarily federally funded at about 75%, and we do receive about 25% general funds. We are considered a self-governing organization, but we work right alongside the Nevada Health Authority to make sure that our work is done. We have 4 full-time employees, and we also have 2 interns that are funded through vocational rehabilitation. So we have a total of 6 of us over here. 1 of our interns is located in the South, and the rest of us are in Carson City. We currently have 21 council positions on our council, and our council is primarily ran by individuals with intellectual and developmental disabilities or their family members. The rest of the roles are made up of agencies throughout the state. We have 18 of those positions currently filled, and so if you or your loved ones are looking at joining any councils or commissions, we are looking for applications as well, and our members are governor appointed. Some of our major future activities that are going to be taking place in this next fiscal year include a DEF conference in December of 2026 in Las Vegas, a self-advocacy conference in the summer of 2026, but we have not come up with a location for that. Partners in Policymaking is a class that we put on every year that teaches individuals with disabilities and their family members on how to be involved in the legislative process. Our Youth Empowering Students program is up and running, and it will be in hopefully the schools statewide. Our I Can Bike camps teach individuals with disabilities how to ride bikes, and we put those on each summer as well. We're also deploying Momentum Refresh mobile restroom units, which include adult-sized changing tables and fully accessible restrooms throughout several events throughout the state in the next year or so. And we are looking for partners on that as well. And we also work on emergency preparedness with the access and functional needs community. And lastly, and most importantly, we are in the process of procuring feedback on our proposed 5-year state plan. That plan is to take place October 1st, 2026 to September 30th of 2031. But the majority of everything that we do comes from the voices of the community. So if you're interested in making sure that you have a voice in the plans that we're doing, we are interested in hearing from you. So thank you so much, everybody, and I'll hand it back to Melinda.
Thanks, Catherine. All right, I'm going to pass it off to Erica.
Thanks, Melinda. Good afternoon, everyone. My name is Erica McAllister, and I am the School Health Services Liaison for the Nevada Health Authority. I'm going to give you a quick overview of the major projects we're working on in the School Health Services team. Essentially, the School Health Services program supports school districts with reimbursements for delivering Medicaid-covered health services directly to their students in the schools. In this first box here on the left, I've highlighted our Centers for Medicare and Medicaid School Health Services Expansion Grant. This is a 3-year grant that supports Nevada's efforts to expand access to school-based services. A big part of this grant includes procuring a statewide electronic health record and billing system to help school districts bill Medicaid more efficiently. In the next box on the top middle, you'll see we have officially launched our School Health Access Resource Center, or we call it the SHAW Resource Center. This is a website which is our go-to hub for guidance and tools for schools and their providers. It includes our program guide that breaks down the Medicaid policy into easier to understand terms. And we host our monthly office hours. And beginning next month in August, through partnership with the Nevada Department of Education, we will be hosting a series of sessions that are called the Multidisciplinary Information Sessions. And then I've got our website listed right there. You can find our resource center there. In the next box, we have several statewide work groups that our team participates in, including the Interconnected Systems Framework and the MTSS Alliance for School Mental Health. Our goal here with these work groups is to ensure that Medicaid is being aligned with broader systems of care, reducing silos, and keeping school health needs represented in cross-agency work. On the bottom left box, we have our annual survey. And we just wrapped up our second annual survey with our schools, where we got strong participation from nearly every school district in the state. This data feeds into our broader evaluation framework, and we'll be using this information to guide our statewide school health services tour this fall, which is where we plan to connect directly with our school districts in person. Next, we have our policy updates. We've been leading important policy updates to support school health services expansion in Nevada, which includes our state plan amendment, which expanded covered provider types in the behavioral health realm. And we've also updated our Medicaid Services Manual, Chapter 2800, to better clarify Medicaid requirements for schools and to improve the policy usability for our schools. And finally, on the bottom right, we have our School Health Access, or SHA, Steering Committee. This is a diverse group that brings feedback from the field, advises on program improvements, and helps us shape everything from website content to policy updates. Their input from this group has been super helpful in keeping our work grounded and reflecting the needs of the schools in our state. Essentially, the School Health Services Program is about building sustainable system that helps schools deliver care and get reimbursed for it, which helps Medicaid be a better partner in supporting our students' health. And next, I will be passing it off to Ashley.
Good afternoon, everyone. My name is Ashley Barton, and I'm a project manager at Nevada Health Authority under the Enterprise IT and Innovations Office within the Director's Office. I'm here to provide an update on Nevada's All-Payer Claims Database, APCD for short, because we all love acronyms here. This project is being led by Nevada Health Authority and managed by our vendor OnPoint Health Data. This program is aimed to boost healthcare transparency, support better health policies, and evaluate healthcare programs. And it's all thanks to Senate Bill 40 from the 81st 2021 session of Nevada Legislature. We've hit some pretty exciting key milestones on our journey towards implementation. In phase 1, we adopted regulations, launched the registration portal in December, and followed up with a website launch at the end of December, beginning of January. We're currently in phase 2 of the project, which includes basically since February 1st up until now, we've been collecting data from our registered data submitters. And since March of 2025, OnPoint and Nevada Health Authority have been developing the APCD Analytic Enclave system, where the submitted data is going to be stored. So we're pretty excited to announce that our first data extract will be delivered by September of this year, with the first data delivery expected by November. If all goes according to plan, we'll receive our second set of data delivery and be fully implemented by December of 2025. So stay tuned for the rebranding of our website under the new Nevada Health Authority. If you want to visit our website, you can go to apcd.nv.gov. And now I'll pass this along to Ann Jensen to provide an update on everything happening within the Division of Nevada Medicaid. Thank you.
Thank you, Ashley, and good afternoon, everyone. It's lovely to see you all. Thank you again for joining us on this Monday afternoon. For those I haven't met, my name is Ann Jensen. I am the administrator of Nevada Medicaid and previously served as the innovation officer here, working on our children's behavioral health transformation, as well as some of our rates analysis and development and value-based payment setting. So if you'd be willing to go to the next slide, Melinda, I'm excited to share a little bit more about what our Medicaid division looks like. And as Stacy mentioned earlier, the intent is really, particularly within our Medicaid division, for this work to feel relatively similar and for the arrangements to be pretty similar to the teams that you all have been working with and hearing from over the past few years. So the way we're organizing this will be within 3 areas. One is focused on community supports. The second is focused on our Medicaid program and policy. And the last area is focused on federal compliance and innovation. So that first bucket, as I mentioned, community supports, includes our district offices and care coordination services, our home and community-based waivers, as well as our more general long-term services and supports, and our non-emergency transportation services. On the program and policy side, that includes our managed care program, access and quality assurance, benefits across medical, dental, and behavioral health, and innovative payments and rates as well. Not listed here, but very closely tied is our pharmacy team, which I'm really thankful to be partnering with us on all of these programs. And then lastly, federal authorities and compliance. As Stacy shared, there are so many details about what goes into our partnership and contract with the federal government. So whole army of folks that are really dedicated to ensuring we remain compliant and are using our authorities in a really innovative and creative way. As noted on the bottom, I think what's really crucial and exciting about our health authority organization is that we work really closely with each and every one of those other divisions. And that in the Medicaid world looks and feels like teams that are dedicated to Medicaid work, even living within our partner divisions. So the Division of Consumer Health is our partner for Medicaid eligibility policy. That division for healthcare purchasing and compliance is our partner for all things provider enrollment and licensure and surveillance utilization review. And of course, our director's office is really closely tied to our work in the realm of budget and fiscal, technology, and community engagement. So really appreciative and thankful to be part of this overall structure as we really hold the core of the Medicaid program policy and resources, but it's really a team effort to ensure that Nevadans across our state continue to receive access to real high quality Medicaid program. So with that, I think we'll shift to our next slide as it relates to Medicaid session impact. I'm really excited about this. It's fun to see the final or the next stage of our process. We had over 150 bills that we were tracking that had some sort of impact on Medicaid. And we had over 120 fiscal notes that our team submitted on those bills. And what we've landed on in total are 43 bills and budget items that were approved by the legislature and signed by the governor that impact our Medicaid program. We have a really robust implementation process that includes the alphabet soup of acronyms you'll see in the blue boxes here on this slide. But know that we have, I think we have nearly 100 people that are working on implementation on nearly a daily basis as part of their core work that are really developing what these new or enhanced programs or resources for our community will look like as a result of the legislative session. So again, cheat sheet for all of our Medicaid language here that we use in the realm of implementation, and I'm really excited for our team to talk about some of those details in the next slide. So the first person I'll hand off to here is Jeremy Hayes, who's our chief of our rates analysis and development unit, with some exciting updates on some rate changes.
Awesome. Thank you so much, Ann. So I'm just going to go over a number of bills and a number of budget items that were passed during the session. Starting off with SB 185, reimbursement for the care of disabled and chronically ill children. Moving into budget items for mobile crisis rate reforms. We do have adult dental coverage that's coming online. I believe that Sarah's going to talk about that a little bit later. Then moving into our partial hospitalization rate increase, rate increases for day treatment services, and then finally SB 424, that's our ambulance rate increase that's going to be funded by a new provider tax. One thing of note is that notice of this new provider tax was posted prior to the reconciliation bill passage in order to lock in that new program. With that, I'm going to hand off to, I believe, Sarah Dearborn.
Great. Thank you so much, Jeremy. I appreciate it.
Thanks.
Good afternoon, everyone. My name is Sarah Dearborn. I'm the chief over our medical, dental, and behavioral health benefits coverage. This first slide of benefits touches on the bills related to behavioral health that were approved impacting Medicaid eligible members. So diving right in, the first, Assembly Bill 380, revised requirements for the makeup of mobile crisis teams. The behavioral health benefits team just hosted a public workshop last week on proposed changes to the new Medicaid service manual for crisis services, allowing for emergency response to be included as part of the mobile crisis team. The proposed new MSM chapter 4400 for crisis services will also be heard at our September 30th public hearing with an October 1st effective date. The next bill on the list is Assembly Bill 514. This requires Medicaid coverage for rehabilitative residential mental health services, as well as licensure for these types of providers. This will require a state plan amendment for reimbursement and coverage of the new service model, new Medicaid service manual policy, likely living in MSM 400, and development of a new provider type and or possible specialty for providers to enroll in. Although this isn't technically effective till mid-2026, we are hoping to get this one lifted and off the ground and hoping for a very early 2026 effective date. The next bill is Senate Bill 300. This part of this bill actually required two initiatives within Nevada Medicaid. So first initiative was to add additional behavioral health providers like licensed clinical professional counselors and their interns and licensed substance use disorder treatment providers to be able to perform behavioral health services under the federally qualified health center behavioral health encounter. This newly added policy language will be heard at our public hearing tomorrow, so I hope you all join us for that. So with an effective date of July 30th. Additionally, with this bill, Nevada Medicaid is required to increase the rate for medication administration services for individuals with opioid use disorder through opioid treatment programs by March 1st of 2026. The next bill, Senate Bill 353, requires Nevada Medicaid to develop coverage and reimburse for behavioral health services performed at university behavioral health training clinics. This will require a coverage and reimbursement state plan amendment, a new Medicaid service manual policy language, as well as the development of a new provider type or possibly provider type specialty. This has an October 1st effective date, allowing Medicaid to submit to our federal partners at the Centers for Medicare and Medicaid Services, also known as CMS, by December 31st of this year. Next is Senate Bill 54. So this bill requires Nevada Medicaid to develop coverage and reimbursement for medical respite services for Medicaid members experiencing homelessness. This will require Nevada Medicaid to apply for an 1115 demonstration waiver in about mid-2026 in hopes of targeting an effective date of July 1st of 2027. There will be additional initiatives needed to support this, like a new Medicaid service manual policy, as well as a possible new provider type or provider type specialties. Lastly, on this slide, a couple new models were approved within Senate Bill 501, which was the Medicaid budget. This includes assertive community treatment and coordinated specialty care services for individuals experiencing first episode psychosis. Program development is well underway with development and coverage and reimbursement for a state plan amendment, a new Medicaid service manual policy, likely living in Medicaid Services Manual Chapter 400, and development of new provider type specialties. Please be on the lookout for an upcoming public workshop in August with submission to CMS and public hearing no later than our September 30th public hearing date. Next slide, please. All right, so next we will move on to Nevada Medicaid's medical program benefit initiatives. So first up, we have Assembly Bill 169, which requires Nevada Medicaid to cover speech language pathology for the treatment of a stutter for all persons under 26 without limitation or prior authorization. Nevada Medicaid will need to amend Medicaid Service Manual Chapter 1700 policy at the October 28th public hearing and implement system updates to comply with the removal of prior authorizations for these services. Next is Assembly Bill 176. So this prohibits the state from implementing limitations that burden contraception, and family planning services. Nevada Medicaid currently does not have prior authorizations or limitations for these services. So we're in good shape with this bill. Next, Assembly Bill 284 requires Nevada Medicaid to implement and reimburse for vagus nerve stimulator therapy device codes, which will require a Medicaid Management Information System, also known as MMIS, update by October 1st of 2025. Nevada Medicaid already reimburses for the procedure to implant or replace a vagus nerve stimulator device. These new device codes will likely require a reimbursement state plan amendment as well. Next is Assembly Bill 360. This requires Nevada Medicaid to reimburse for the cost of rapid or point of care testing for syphilis for pregnant women performed under certain circumstances separately from reimbursement for other prenatal care. This will require a Medicaid Service Manual update to Chapter 800, planned for our October 28th public hearing to meet an effective date of January 1st, 2026. Next, Assembly Bill 428 requires Nevada Medicaid to develop coverage and reimbursement for any procedure or service for the preservation of fertility of a Medicaid member who has been diagnosed with breast or ovarian cancer, in which the cancer or treatment for that cancer may directly or indirectly cause infertility. This will require Nevada Medicaid to apply for a Section 1115 demonstration waiver in hopes for the spring of 2026 for an approval by January 1st, 2027. Along with an 1115 waiver, this will require new Medicaid Service Manual policy as well as system updates with possible new provider type. Finally, Senate Bill 344 requires coverage for non-invasive prenatal testing for chromosomal abnormalities. This will require an update to Medicaid Service Manual Chapter 600, which we're targeting for an October 28th public hearing date, along with the system update to be ready for a January 1st, 2026 effective date. Now I will turn it on over to Kirsten. Thank you.
Thank you, Sarah. Hi, I'm Kirsten Kulam. I'm the Chief for Long-Term Services and Supports with the Division of Nevada Medicaid. And while we don't have as long of a list as Sarah does on those two slides, we certainly have some exciting new programs. So the first I'm going to talk about is Senate Bill 185. It is essentially personal care services for children that will be reimbursed through a family member. And so we are grateful to have new staff to be able to hire to support that new program. And we know that there is a lot of interest from family members, and family members want to give us feedback on how we develop that program. So one of our first activities will be kind of that stakeholder engagement specific to our personal care services for children. It will require us to develop a new home and community-based authority. So we're still evaluating whether that will be a HCBS 1915C waiver or perhaps a HCBS 1915I state plan option, just two different types of Medicaid authority that has different paths. And so we'll be evaluating that. And because those are new HCBS authorities, we have a longer ramp up period. So it's at least 180 days for a federal review. And then we'll also have those system updates. So we have some tentative timelines. As we get closer to looking at that implementation plan, we will certainly be pushing out notifications through our listserv, holding public workshops and these stakeholders engagement as we develop that process. So far sooner before the effective date. And then the next one that LTSS will be implementing is PACE. So many of you may have heard about PACE, may not know what the acronym is. So it's Program of All-Inclusive Care for the Elderly. This has actually been around for a long time in our statutes, but we didn't actually have funding available for that. And so that's very exciting that we do finally have that available. I'm also grateful for the new staff that will be able to stand that up, because that is definitely a different service delivery model than we are typically see an LTSS through that fee-for-service delivery. It's more of that comprehensive bundled opportunity. We will also be holding stakeholder engagement for that. We will be contracting with the vendor. PACE can be a little bit complicated in terms of what that looks like, developing the service areas, submitting that to the new state plan to CMS, the Centers for Medicare and Medicaid Services. So we'll have some activities to have the state essentially contract with that vendor to help us develop that. And then we'll also have those policy updates, state plan updates that we're looking towards July of next year. And then lastly, not a new program, but a new opportunity through our behaviorally complex care program, which is currently available for our nursing facilities, and really a great program that we have. And this is just an opportunity to really enhance that program, to add in quality measures so that they'll have a incentive that you can have for that, for the increased rate associated with those quality incentives. Hiring new staff for that. We'll have to develop those quality metrics. And then certainly we will be engaging stakeholders on what those quality incentives should look like. This will require a state plan amendment, and then potentially some system changes as well in order to be able to issue that quality incentive. And so that one is also July of next year. And I will turn it over to Dr. Duncan.
Thank you. All right, so for pharmacy and DME changes, first up we have SB 389. Which was for a single state pharmacy benefit manager. This would be effective no later than January 1st, 2030. This is a rather extensive process that will involve procurement. So we will be doing an RFP, and then of course your the regular SPA and policy changes and testing phases. So this will take some time and will be implemented in partnership with many units and many of our new divisions in the Health Authority as well. There was also AB 284, which affected rates of reimbursement for the cost of a vagus nerve stimulation therapy device. This would be effective at least by March 1st of 2026, and this does require some CMS and policy changes. One of our big announcements, though, that will be coming up before all of these things is that Nevada Medicaid pharmacy benefit will be moving to a single preferred drug list. That is effective January 1st, 2026. This will be inclusive of our medical pharmacy drugs as well. So the drugs that are billed through the medical benefit, not just the pharmacy benefit, the diabetic supply program, and all utilization management requirements that are under the pharmacy benefit. So that includes things where we have quantity limits and prior authorization criteria, clinical criteria, and such that needs to be completed prior to receiving approval for certain medications on our list. And that single PDL, that's going to be utilized across all managed care organizations in the fee-for-service program. So as it stands today, we have 5 different preferred drug lists that have to be followed, and this will unify it all to a singular one for the Nevada Medicaid pharmacy benefit. So that's the updates I have, and I'll turn it over to Dr. Benson.
Thank you, Dr. Duncan. Again, my name is Dr. Keith Benson, the Nevada State Dental Officer with the Nevada Health Authority. I'm very excited to report that the governor's budget under E267 includes additional adult dental Medicaid benefits, and it will require a number of changes, including a state plan amendment, MSM updates, as well as system changes. We'll be working with a third-party vendor to help gather stakeholder input and also to develop the benefit by sharing what has worked best in other states and what we can best implement here in Nevada. This adult benefit will be effective in the second year of the biennium, starting July 1st, 2026. Also, Assembly Bill 334 was passed, helping with our dental hygienist shortage by easing restrictions for Nevada licensure, and no system or federal updates required by Nevada Medicaid. We're ready to go. Senate Bill 268 requires insurers pay for services performed under the public health endorsed hygienist provider type, And again, Nevada Medicaid is already compliant and no system or federal updates required. Lastly, the 1115 waiver is close to being live for participating federally qualified health centers and tribal health centers. This waiver allows for reimbursement for dental services for Medicaid adults living with type 1 and type 2 diabetes. Our billing system is projected to be live in just a few weeks, and we are also working on communication and billing education to our 11 partnering dental clinics. Thank you very much for your time, and I'll pass it on to Ann Jensen.
Thank you, Dr. Benson. So in addition to all the excellent work that you've heard about from the teams on the kind of ongoing basis to move forward for our program, we also have other major projects that are kind of above and beyond our day-to-day program work that I'm excited to share a few updates on. So the first one is on our children's behavioral health transformation. If you want to move to the next slide, Melinda. This really is our effort that we have shared a lot about, so I won't go into too many details, but I'm excited for this full group to hear the significant progress that we've made over the past year. The goal, again, is to ensure that youth across the state that are Medicaid eligible are able to access home and community-based behavioral health services to help support them in receiving the care they need at home and in their communities and remaining with their families. This is part of our response to the Department of Justice settlement agreement that was reached earlier this year and is led by Nevada Medicaid under the new Nevada Health Authority. The reorganization of the Health Authority does not change our effort. We're moving forward very quickly in this work, and there's two main areas where you'll see those changes, and many of those have already happened. First is on the Medicaid benefits side. We are developing new Medicaid benefits, meaning Medicaid reimbursement for behavioral health services that are likely already happening in our communities. Those include youth and family peer support, respite care, extensive and coordinated screening and assessment across the state, as well as wraparound and intensive care coordination models that are specific for youth with complex behavioral health needs. The goal is for each of these benefits to be available for eligible youth as part of a new specialty managed care plan. This will launch on January 1st, 2027, which, as we all know, is coming up very quickly. I'm really excited for this process to move forward, and we've gotten very excellent feedback from our community members, from family members, from youth who have been part of these systems, as well as from our providers and payer partners throughout this process. Our public comment period closed back in May. And we are finalizing the documents for procurement, which will be published this fall. That selection will occur throughout this winter, with next year spent really getting that plan up to speed and in order for that January 1st launch. So if you haven't already, we welcome you to join our monthly behavioral health working group meetings. These representatives formally include youth and family members, providers, and other community members, but we welcome everyone from the community to join and participate. We will continue to get feedback on our specialty plan design. Particularly, we'll be covering care coordination and discussing that in August. So we'd love for you to join us and share your feedback if you're interested. Our website is listed here on this slide, and I'll drop it in the chat as well. And there you can sign up for our listserv and get notifications on updates on this project as well. So with that, I will turn it over to Cynthia.
Thanks, Anne. Good afternoon. My name is Cynthia Leach, and I am the Deputy Administrator for the new Office of Medicaid Inspector General. Nevada Medicaid's new Provider Flex tool fully and successfully implemented on July 8th, 2025, with the goal of having a streamlined, intuitive, integrity-based provider enrollment solution. Some of the key features include a streamlined dashboard, an intuitive attachment process, error identification, meaning the system will automatically show what still needs to be completed and won't let users submit an incomplete application, easy access to data and auto-saving, and last, integration of DocuSign functionality. We're still gathering data, but preliminary stats show roughly 75 to 80% of all applications are successfully completed the first submission, which is an overall improvement over the former online provider enrollment tool. Additionally, the total time to disposition an application is averaging just about 7 days, which is also an improvement over the previous processing times. We will continue to monitor these metrics and look for opportunities to improve. Some important reminders for providers: no action is needed from enrolled Medicaid providers today unless or until it is time to revalidate enrollment or if there's a change in ownership or status. In the new Flex tool, all enrollment documentations require an electronic signature from the provider or owner. So as part of the DocuSign signature process, the signer will be required to upload an image of their state issued ID and include a liveness video for validation. Resources, training opportunities, FAQs, and pertinent web announcements can all be found at the website listed. Next slide, please. Next, we have a project update for centralized credentialing. Credentialing is essentially the second step in the enrollment process and applies to providers who contract or intend to contract with one of Nevada Medicaid managed care entities. The project went live back on February 28th. We've contracted with Verisys, a credentialing verification organization, to provide primary source verification services and to facilitate a bi-monthly credentialing committee. The committee adheres to NCQA guidelines and streamlines the credentialing committee approval process. For recredentialing, Verisys is aligning common providers across the managed care networks and identifying the earliest date to trigger the required 3-year recredentialing process. This means providers will only need to recredential once per 3-year cycle, and the credentialing result will apply to all managed care networks. To date, Verisys has completed almost 7,000 provider credentialing applications for Nevada Medicaid. On average, it takes about 10 days to perform primary source verification, allowing for a timelier committee decision process. More information, including frequently asked questions and managed care plan resources, can be found at the link provided. Thank you. And now I will turn it over to Jamie Evans for the next update.
Thank you, Cynthia. As you know, Nevada Medicaid will be expanding managed care statewide effective January 1, 2026. That means that roughly 65 to 70,000 rural Medicaid members will be covered under managed care. During the procurement phase, we received 6 competitive bids and ultimately awarded contracts to 5 vendors. 4 of those are returning partners, and 1, CareSource, is new to the Nevada market. Plans were awarded specific geographic areas, with Anthem and Molina continuing to serve urban Clark and Washoe counties, Health Plan of Nevada serving Clark County only, and Silver Summit and CareSource serving all counties, including rural and frontier Nevada. Implementation activities are underway. We've begun onboarding CareSource and are collaborating with all of the MCOs on detailed implementation plans that outline key deliverables and timelines. We're working with our fiscal agent to update our internal systems, collaborating with sister agencies and other vendors to support the changes, and working with our external quality review organization to complete readiness review activities. Our communications work group continues to develop messaging for Medicaid providers and community partners, including updating our statewide managed care webpage, sending listserv announcements, and of course the stakeholder workshop. We're also collaborating with MCOs and community partners to facilitate at least one town hall event in the coming months. Nevada Medicaid is actively developing a process to allocate the current caseload across all 5 vendors beginning January 1, 2026. This means some of our members will transition to different MCOs. We're working hard to make this process smooth and well communicated via several methods, including listserv, the Nevada Medicaid app, letters, and webpage updates, just to name a few. Members will have a 90-day choice period to make a change after January 1, 2026, even if they're moved to a different MCO. Nevada Medicaid is dedicated to supporting members throughout this transition. Looking ahead, we will update the state plan and Medicaid services manual to reflect the statewide expansion and start of the new managed care contract. Providers and community partners can reach out to statewide MCO at dhcfp.nv.gov with any questions. Members can reach out to Medicaid at nvha.nv.gov. Just to let everyone know, we are here to help, so please reach out if there's any questions. And I will now turn it over to Michael Gordon.
Hey, thank you very much, Jamie. Afternoon, all. My name is Michael Gordon. I'm the Federal Waiver Director. As many of you know, we've been talking about our reentry initiatives for quite some time, and in previous stakeholder engagement meetings. So just a reminder, we have the CAA, which is the Consolidation Appropriation Act 5121, back from 2023, which provides 30 days of pre-release and 30 days of case management for those who are under 21 years of age or aged out of foster care, use up to 26, and are post-adjudicated. So those are those folks can get screening and diagnostic services, and like I said, targeted case management for up to 30 days post-discharge. With that, we do have our waiver, and I'm going to skip down to the bottom middle there. Our 1115 re-entry waiver, which provides, again, pre-release services, which is going to be 90 days prior to release, and the 30 days of targeted case management for those who meet the CAA requirements. So those are all going to be combined into one program throughout the state to make it easier for all of our stakeholders. We have been meeting with stakeholders on our bi-monthly reentry advisory committee meeting. And just a reminder for those, that third advisory committee meeting will be tomorrow afternoon. And if you are not already on our email or our notices, the addresses are there on how to get involved. And that way you can get signed up if you want to get involved on those. We do have a CMS grant for $5 million over 4 years that we are working with CMS on. We're waiting to be awarded those funds, and that'll help us with both programs and getting that all put together into one big initiative to make it easier. And last but not least, I have our policy and provider type update. We are continuing with the help of all of our stakeholder engagement to build and implement our programs for reentry initiatives. So we're still creating our policy guidance right now. And we do have a new provider type, 98, and that'll be for city, states, and municipals that have either carceral facilities, detention facilities, and that'll allow the billing for reimbursement on Medicaid dollars. And with that, I am going to hand this over to Todd Rich.
Great, thank you, Michael. Hey, good afternoon, everyone. My name is Todd Rich. I serve as the administrator of the new Healthcare Purchasing and Compliance Division. I joined Nevada Medicaid last December, came over to help stand up the public option battle-born plans, which you're going to hear more about in a minute. But I wanted to give you an overview of our new division. I think it's very exciting in terms of what's happening and how we can move forward. I'm going to talk in detail about our new section, which is our purchasing and contracting unit here in a minute. But there's really 3 units that make up this group. We also have our Office of Inspector General. You heard from Cynthia Leach a few minutes ago. She does a great job in overseeing this area, which deals with provider enrollment. Lots of new exciting things happening on the centralized credentialing. And then her team works a lot with the fraud, waste, and abuse, making sure that we are, excellent stewards of the public funds. Coming over to our new group is the Healthcare Quality and Control Bureau. And we wanted to keep the name the same. We didn't want to change it. We wanted to make sure that our stakeholders weren't confused. So this bureau came over in full, and they're led by Kyle Devine. And Kyle's got a number of years of experience, and their team does a great job. Melinda, if you want to go to the next slide, please. So I really want to talk about what's happening with our new healthcare purchasing and contracting unit. So our enabling statute, SB 494, provided us the overall authority to create statewide purchasing strategies. And so what we want to do, probably first thing, is come up with some ideas that can help us. And so we're going to put out some quotes and a request for quotes so we can bring in some vendors that will help us develop really comprehensive purchasing strategies so that when we go to purchase healthcare or whatever it is, we're really going to leverage everything we can. When you look at all the moving parts that Director Weeks talked about, we brought over the Public Employees Benefit Program, the Silver State Healthcare Exchange, and obviously we have Medicaid. And when you add all those covered lives together, it's almost 1 million in the state of Nevada. So we can really leverage the strength and go out and hopefully get better deals, because we know healthcare costs are not going down. So we really have to be really strong in terms of what we purchase and make sure that the state uses every dollar effectively. Senate Bill 494 also provided our new health authority with purchasing authority to go directly out. So we don't really work with state purchasing anymore. So we're going to be bringing on a new attorney to help us make sure we stay out of trouble, but really provide us legal guidance in terms of moving forward with this new strategy. And then we'll be drafting regulations that will help us drive some of these new processes that we will be doing. So we'll be actually running our own RFPs, and from start to finish, from bringing in the vendors and all the way through to the contract negotiations and signing all the contracts. So lots of good work that will be happening soon, and very excited about the things that we'll be able to accomplish. So I think that's it. I'd like to hand it over to Paul Schubert, who's going to talk about some specifics with healthcare quality and compliance.
Good afternoon, everyone. I'm Paul Schubert, Chief of the Bureau of Healthcare Quality and Compliance. And we actually do more than just license, certify, and investigate compliance in healthcare facilities. We also license personnel such as laboratory personnel, dietitians, naturopaths, and others. We also license and approve educational programs such as domestic violence and cultural competency training. We issue environmental health permits and health facility kitchens, their pools and spas, and we do sanitation inspections in state prisons. And now we will be engaged in permitting cosmetic manufacturing and septic systems in certain rural counties. And we will also be doing sanitation inspections in schools in certain rural counties. So HCQC has an annual budget of approximately $22 million and employs 109 staff to accomplish the Bureau's workload. Now I'll go through the legislation we are responsible for from the 2025 session, and we have touch points for approximately 18 bills. So AB 50 requires certain hospitals and independent centers for emergency medical care to establish mass casualty databases. AB 161 establishes a hospice bill of rights for hospice patients. AB 176 prohibits burdening of access to contraception and family planning. And you heard about that one with Medicaid's presentation. AB 221 exempts physicians that are also licensed dentists from permitting requirements associated with the use of sedation. AB 360 requires testing for sexually transmitted diseases during pregnancy. You also heard about that one with Medicaid's presentation. Next slide, please. So AB 368 extends the allowance for electronic communication devices that was passed last session for nursing homes to now include assisted living facilities. AB 483 requires prioritization of licensing of healthcare professions in underserved areas. And again, HCQC licenses several different healthcare personnel. AB 484 requires collection of certain data concerning our licensees, and we'll be accomplishing the data collection during license renewals. AB 514 establishes a new facility type, providers of rehabilitative residential mental health care, and we'll be working with our Medicaid partners to establish regulations for the licensing standards. AB 519 moves personal care attendant and intermediary services organizations to a new chapter outside of Chapter 449, which is primarily used to regulate healthcare facilities. Next slide, please. AB 521 requires collection of information about child abuse for certain healthcare facility applicants and staff. We've collected background information about certain convictions for many years, but this adds a child abuse registry check. AB 544 is an agency bill that will adjust our health facility license when our health facility licenses expire and renew. And then SB 84 requires domestic violence training programs to be evidence-based. SB 188 requires certain healthcare facilities to provide interpreter services. And SB 189 includes genetic counselors as healthcare providers. And next slide, please. So SB 274 removes an element of one of the reports we provide to LCB. SB 299 establishes new licensure type for referral agencies. And SB 330 amends the definition of a SNF by adding the term inpatients. And that's all for HCQC. So I'll turn it back over to Todd or Melinda.
Thanks, Paul. I am going to hand it off to Jennifer Krupp.
Good afternoon, everybody. I am Jennifer Krupp. I am the new administrator of the Division of Consumer Health Services. This is one of the new divisions that was created under SB 494 in the Nevada Health Authority. And if we could please transition to the next slide, I will tell you a little bit more about us. So the division overview, the division does bring the Silver State Health Insurance Exchange and Medicaid eligibility policy and the Battle-Born State Plans, or is more commonly known as the public option, all under one umbrella. So the goal of the Consumer Health Services is really to help get people covered and keep people covered. And we're doing that by bringing in the exchange and Medicaid eligibility policy and Battle-Born State Plans so that we can help coordinate and collaborate across these three programs to make sure that we are finding clear pathways to coverage and to be able to identify ways that we can help assist with ensuring people are able to achieve that access to care that Stacy had talked about earlier through having, viable payment methodology or viable payment policies in place so that we can sort of improve that access to care. So the Silver State Health Insurance, which we will talk about a little bit more in depth next, does operate the state's health insurance marketplace, which is also known as Nevada Health Link. As this is a newer agency underneath not only the Nevada Health Authority, but under the umbrella of Consumer Health Services. I will have Katie give an update next. Medicaid eligibility policy is going to be setting and updating policy for the state's Medicaid and CHIP, or also known as Nevada Checkups programs. Again, as we discussed earlier today, there's quite a few high impact eligibility changes that were passed under OBA for Medicaid and the exchange. And we also have several eligibility updates for the exchange that were finalized under the Marketplace Program Integrity Rule that will become effective at the end of August, and we'll have different provisions that will take effect, that will become effective between now and the end of 2028. And then finally, we have Battle-Born State Plans and the Market Stabilization Program, which are both authorized under Nevada's 1332 waiver. So next slide, please, Melinda. And this, I will pass over to Katie.
Hi, everybody. My name is Katie Charlson, and I'm the Communications Officer with the Silver State Health Insurance Exchange. As Jennifer said, we're the state agency that operates Nevada's health insurance marketplace, known as NevadaHealthLink.com. You also may hear us be referred to as the Exchange or the Marketplace. Just a few quick updates. So we have been working closely with previously DHEFP, Nevada Health Authority, and the Battle-Born State Plan. So we launched a dedicated landing page at NevadaHealthLink.com/BBSPs, which will serve as a central hub for information. This page will continue to be updated in the months leading up to open enrollment. Our marketing agency has developed a custom BBSP logo to help brand and differentiate these plans. Plan certification is currently underway to ensure all BBSPs are going to meet our state and federal standards, along with all of our standard qualified health plans. Our window shopping begins October 1st, and for open enrollment, we will add a BBSP visual identifier to the plans and also a filter option that will help Nevadans easily identify these plans. And for some of our communications and marketing updates, we have been actively preparing for our upcoming plan year 2026. We are launching a new text messaging campaign to help notify current enrollees of upcoming changes and encourage them to actively shop for the best plan available. And then our plan year 2026 marketing campaign built on last year's animated series. But this year, we're really emphasizing on value over cost savings, because we know these subsidies are likely ending, these extended subsidies, and also some rate increases. So really talking about, like Jennifer is saying, the value of having coverage, using your coverage, and talking about what Nevada is doing, like the Nevada Health Authority and Battle-Born state plans to help improve these health outcomes for Nevadans. We are also working on our broker and navigator certification process. We work with a network of nearly 1,000 certified brokers and navigators, and they are a cornerstone of our success. These professionals provide free enrollment assistance to Nevadans statewide. All of our broker and navigators are required to complete an annual training and certification. This year's updated training will launch September 2nd, 2025. We've also selected our broker and navigator awardees. Our brokers are yearly for the fiscal year, and then our navigators are every 2 years. We have 11 broker grantees this year and 7 navigator awardees. And some quick policy changes. There is a lot more than this. This is a very high level, but as Stacy mentioned at the beginning, DACA recipients will no longer be eligible for marketplace coverage effective August 25th of this year. So we are currently working on notifying these recipients and working with them to let them know about maybe different options they have, or if they have a mixed status household, making sure that the other people in their household are remaining covered. And our policy team, recon QA team are really working diligently on that right now to ensure everyone impacted are notified about these changes. We are also preparing for the likely expiration of enhanced subsidies that were introduced during the pandemic. Again, communication and system updates are underway to support a smooth transition, really encouraging our recipients to shop, work with a navigator or broker is kind of our main messaging this year. And then we have a lot more rule changes. I have to read those in the next one, but as Jennifer said, most of them are beginning next year, such as we'll have a shortened open enrollment. So an open enrollment for state-based exchanges can be no longer than 9 weeks. So next year, our open enrollment will go from November 1st to December 31st, most likely. There's also more lawfully present changes. So those will be coming up in the coming months and for next year. But for right now, that is all I have.
Thank you, Katie. So I'll give you guys a brief update on the Battle-Born state plans and the market stabilization and waiver program. So the Battle-Born state plans was established under SB 420 in the 2021 legislative session, and it is now found under NRS 695K. These are new state contracted plans, which do launch on January 1st of 2026. And these new state contracted plans are authorized, like I said, under Nevada's 1332 waiver with the intention of expanding coverage options within the marketplace. We do have 3 carriers, Silver Summit, which is a Centene Company Health Plan of Nevada, and Community Care Health Plan of Nevada. We will have Battle-Born state plans offered in all 4 rating regions across the state. And these state contracted plans must meet certain benchmarks, such as premium reduction targets to help improve affordability for consumers. These plans will be available this open enrollment for purchase by consumers through Nevada Health Link or the Silver State Health Insurance Exchange, but on the Nevada Health Link platform. And open enrollment, as Katie said, does start November 1st of 2025 for plan year 26, which goes January 1st through December 31st of 2026. And then the market stabilization and waiver program, the reinsurance program launches in January of 2026. And the market stabilization program reduces premiums in the individual market by reimbursing carriers for high cost claims. And so this helps bring down the overall cost of insurance premiums within the state for health insurance coverage. We will be launching a premium relief program in 2026, though that does look like that will be happening more towards the end of the year once we start to get data in with the implementation of our market stabilization waiver program. And then if additional federal funds are left over from those federal pass-through dollars that are received, the state will invest those in a quality incentive program, which we will have additional details for soon. I would now like to pass it over to Vanessa Rami, who is with the Enterprise IT and Innovations Office.
Thanks, Jennifer. Good afternoon, everyone. My name is Vanessa Ramey. I'm with the Enterprise IT and Innovations Office within the Director's Office. I will be supporting and overseeing this project, which is very exciting. The primary purpose of this project is to modernize and transition eligibility and enrollment to most Nevada Medicaid applicants from the existing eligibility system to the exchange platform at Nevada HealthLink. The Medicaid Express will be the gateway to coverage that meets Nevadans where they are and puts choice, dignity, and timely care front and center. This strategic shift aims to reduce the stigma related to applying for Medicaid coverage. It also streamlines the eligibility determination process for most Medicaid enrollees who are eligible for no-touch automated enrollment. It will also allow for enrollees to shop, compare, and select their Medicaid managed care plan. If they're determined not eligible for Medicaid, applicants will be directed online to shop for products on the exchange where they may be eligible for subsidized coverage options. It also provides real-time enrollment, which enables timely coverage to essential healthcare services. Currently, this project is in its planning phase. We're planning to roll this out in a phased approach. As you can see in the diagram, our proposed phase 1 outlines that we're in the planning and will begin design and development in November with implementation of this first phase August of 2026. That concludes my update for this project. I think I will be handing it over to Nick Proper, who will be talking to you about the public employee benefits. Thank you.
Thank you. My name is Nick Proper, and I serve as the Interim Executive Officer for the Public Employees Benefits Program. I'll just be giving a brief overview of some recent changes to the program. So with the passing of SB 494, it has changed some of the board member election processes. This includes the board electing the chair at the first meeting of each calendar year, the vice chair being appointed by the governor, and 2 state employees in classified service being appointed by the Assembly Speaker and the Senate Majority Leader. Some recent plan design changes for the recent plan year that began on July 1st, which is plan year 26. This includes making the embedded basic life insurance amounts equal for non-state employees and retirees. Also increasing the Medicare Part B subsidy to $145.30 and changing the HSA and HRA contributions to $700 per employee with $200 per dependent, up to 3 dependents, just on the high deductible consumer driven health plan. Now I'll pass this back to Melinda.
Perfect. Thank you, Nick. Appreciate it. All right, so I just wanted to do some quick additional updates. Wanted to provide you with some different stakeholder engagement opportunities that you might be interested in, and have a lot of information on this slide. But basically, if you want to reach out to any of our team members, there are a lot of group emails on here. So specifically for the reentry initiatives, if you have questions on that program or want to become more engaged, please feel free to reach out to that team at the 1115 waivers email. And then, as Anne had mentioned, we have the Children's Behavioral Health Transformation. They have regular working group meetings associated with that project as well. And then we have the School Health Services Program. We actually have our next steering committee is tomorrow afternoon. And we have that new website that Erica had talked about, as well as a group email there if you have questions regarding any of our school health services initiatives. We do hold regular stakeholder meetings between the Nevada Health Authority and our various stakeholders that are listed here. If you're interested in, us hosting additional meetings, please feel free to reach out to me. I can insert my email into the chat for you all, or you can also reach out to that community and provider email at the bottom of that regular stakeholder meetings box. We also have regular tribal consultations with our tribal stakeholders, and do like to do a lot of in-person tribal outreach visits and different ad hoc consultation meetings, of course, with our tribal members. And if you have any questions on tribal stakeholder engagement, please feel free to reach out to Nahibi. Her email address is listed there in that box. And I did want to highlight some upcoming stakeholder and board meetings that we have. We have our new two new committees. So we had previously the, oh my gosh, Medical Care Advisory Committee, the MCAC, has now turned into the new Medicaid Advisory Committee, or the MAC. And then we have a new separate committee that is the Beneficiary Advisory Council. And so both of those inaugural meetings will be held on August 13th. And again, if you have any questions regarding either of those meetings, please reach out to our community and provider email address listed under the regular stakeholder meetings. We also have a substance use disorder. One of our 1115 waiver demonstration projects has a public meeting August 15th, sorry. You can go to our public notices website for additional information on any of these public meetings. And then I also listed information about the Public Employee Benefits Program board meeting. They also have another website to seek additional information, and same with the Silver State Health Insurance Exchange, listed their website there as well. So again, these slides will be available for you on our public notices webpage here shortly so that you can click through all these links. And then lastly, I did want to highlight that we have a new listserv for the new Nevada Health Authority. I copied and pasted the actual page information on this slide. And then once the slide deck is available, of course, you can click that link and just send the email. Okay, and with that, I would like to open it up for questions from the group. So please feel free to raise your hand, use the raise hand feature, and we will go ahead and open it for public comment. Yes, we have our first one. I'm sorry, my computer's a little slow. Okay, so first one is from Robert. So Robert, please feel free to unmute. Or do you need help unmuting? Maybe you might be double muted, Robert. Oh, lowered the hand. Okay, you can feel free to try again. Jose, please feel free.
Yeah, in regards to the waivers, I guess we do medication-assisted treatment, and predominantly we address folks that are unhoused. So that's a populace that's going to unfortunately fit into that that category of patients that are on Medicaid without children, because most of them have either given up rights to their children or do not have children. So if they are on medication-assisted treatment, is there a waiver for the requirement to be working, or how does that work?
What do you mean be working? Sorry, the work requirements?
Yeah.
A waiver of what? Are you asking if we're gonna seek a waiver of requiring it for people on substance use treatment?
Yeah, and maybe I misunderstood, but
Mhm.
what I was
Yeah, no, so in the federal legislation, there are exemptions for people who are actively, I don't have it in front of me, but there are exemptions, and it relates to people who are in treatment. I think the concerns I always have about these types of things is not everybody is actively always in a treatment or diagnosed appropriately. So I think one of the things that we're gonna have to do very carefully is when someone is denied for these reasons for work employment, is ensuring that providers in the community understand that we may need more information about people, or they may need to know, so we can make sure that their eligibility is appropriate. So for example, if you've got someone in treatment or is about to be in treatment, like what information do we need to make sure that we can get them enrolled and maintain coverage? Does that answer your question?
Well, basically, these are patients that are barely capable of enrolling in Medicaid, because a lot of them also have the problem of getting, birth certificates, getting IDs and so forth.
Well, we can't enroll anyone who's not appropriately documented. So that's just going to continue. That's a barrier today. And there's no waiver with this new administration at the federal level for anything outside of the rules.
Okay, and in that case, has there been any thought from Medicaid on maybe coordinating with the DMV to allow for better access for these folks to get appropriate ID?
DME, yes, there was a bill last session, but it did not pass because the feeling of lawmakers is, I think it didn't pass, if I remember correctly, but they have conversation with the DMV if they need to help people get their license. If that's the issue, then we can definitely work with the DMV, but that is their job to, if people are, document all those things immigrant wise, they should be getting their IDs. So if you have a list of examples that you are currently worried about where people aren't getting their IDs, if you want to send those over to Melinda, we'll work with a Division of Social Services and we'll reach out to DMV and push on it.
Okay, appreciate
it. Mm-hmm.
Hey, all right, next it looks like we have Dawn. Dawn, please feel free to go ahead. Dawn, I'm not sure if you're double muted. Not coming up. Let's see, we're gonna go ahead and go to Kate. Dawn, please feel free to work on your mic. I'm sorry that's not working.
If you want to put it in the chat, Dawn, you can. Sorry, Kate.
Yeah, sorry.
No worries.
Kate, did you want to go ahead with your question?
Sure. I didn't know if you wanted to wait for Dawn or not. Okay. So mine, I don't know if mine is exactly pertinent to you guys, but it definitely involved Medicaid. I believe it's waiver or bill. I can't remember if it's a 1115 waiver. It's the idea of gaining access to Medicaid funding for incarcerated patients while they're still incarcerated but preparing to be released into the community. And I know that we don't have that bill or waiver, I'm sorry if I'm not using the right terminology, passed, but I was just wondering if you guys had any kind of update or information about that in general, where Nevada is at on that front.
I can take this, Melinda, if you would like. So we are awaiting the approval of the 1115 waiver from our federal partner, CMS. They did say that they were hoping to get that approval to us in the third quarter, which we just started. And if and when they do get it to us, it's probably anywhere from a 4 to 6 month leeway for us to get all the policies buttoned up and get everything out to the community to get that started.
That's actually amazing. That's wonderful, a little bit further than I thought we were. So at least from my perspective.
The team's been working really hard on that. So we've had the assistance of Annette Health vendor help us. So we were able to move pretty quickly. But again, like Michael said, it all depends on CMS, but I think we're pretty hopeful that they're actually going to move on it.
And that would be eligible for patients both in any incarceral setting, right? Not just prison, but also jail?
That is correct.
Oh my goodness. Okay, wonderful. I will keep looking out for that.
It's pre-release. We preface that? It's pre-release, Kate. So it's 90 days, up to 90 days pre-release. So we would need to make sure we have information. Can't be the entire stay. Yeah.
It's only for patients who actually have a release date to where you can plan while everything's still pending or they're pending trial or some other issue. It does not help us, but you know what? It's something.
Thank you.
We can work with that.
Yeah, I mean, if you want, Blaine, or I'm not Blaine, sorry, I was texting Blaine. Michael, if you want to put in the message, don't we have like stakeholder meetings on some of this or a listserv or something you could put in there so Kate can stay kind of in the loop? Because There's a lot to do around that, Kate, like becoming a billing provider with Medicaid, enrolling. There's a lot of work, but we can get started on some of that with you guys if you're interested.
And Vanessa just posted that,
I would love
and then
that.
yeah, and if you can reach out at any time, Kate, we can answer more questions that you might have.
Okay, that would be wonderful. By the way, just to introduce myself, I'm sorry. I work inside a CCDC. I'm the MAT program provider. So we primarily treat opioid use addiction, or sorry, opioid use disorder. But I know that they're looking at that for many different aspects of our care inside of CCDC.
Thank you.
It's great to meet you, Kate.
Nice to meet you too. Thank you guys. I'm copying this and I appreciate it. Thank you. That was all I had.
Excellent. Thank you. All right, let's see. We have Shayna. Please feel free to unmute and go ahead.
Hello, can you hear me okay?
Yes, but I do have an echo for some reason. Okay, let's try that again.
Are you able to hear me?
It's echoing quite bad.
Can you hear me
Hang
now?
on 1 second. Oh, that's better. Yes.
Darn it.
Go ahead, Shayna. Are you still there, Shayna? Oh, we may have lost her. Okay, while Shayna's getting back on, how about Claudia?
Hi, Melinda. Thank you. I just had a quick follow-up regarding one of the updates that was presented regarding Nevada's PACE program, and that there's an RFP expected in early 2026. And I'm wondering if you're able to share what type of vendor the state intends to engage through that solicitation. So is it an RFP that seeks to identify a pharmacy's benefits administrator? Anything that you can share about what the need is for the state for that program?
I'm going to phone a friend, Kirsten.
Yeah, no problem. And thanks so much for that question. So we're looking to seek a vendor to help us write the RFP for the PACE program. So the PACE program would have an RFP for those selected PACE organizations. And because of the timeline, we will most likely be looking at the vehicles that we currently have for technical assistance to assist us in developing that RFP. So the RFP isn't necessarily for the vendor, it's the RFP is for the PACE organizations.
Ah, okay. It's a very early stage. Okay. Thank you so much, Kristen. That clears it up. Thank you.
My pleasure.
Okay, thank you. Do we have any other questions from folks? Yeah, I'm just going to look in the chat really quick. Let's see. So Shayna was able to type in the chat. What options is the state considering in relation to HR1? Any timeline? There's a lot encumbered in HR1. So I'm not sure how exactly to answer
What
that.
was the question again, Melinda? Sorry, I'm trying to find it.
No worries. It just says what options is the state considering in relation to HR1 and any timeline?
Well, we had several slides on this, so I don't know if you missed that piece of it. So I apologize. I mean, I think there's quite a bit that's going on. The timelines, as I walk through, are pretty delayed in the bill. So this biennium, there's really not much besides making sure we're implementing moving forward in the right direction. We will be having stakeholder public workshops on work requirements, and we start implementing that, as well as cost sharing. But again, all of those requirements around those issues apply to the adults expansion population only. So it does not apply to people with disabilities, parents, children. I just want to clarify all of that. There's been a lot of I totally appreciate where it's coming from, a lot of fear. But I just want to be clear that we don't anticipate making any cuts to this program and feel very strongly that we are going to do whatever it takes to keep moving forward as we have been from a coverage standpoint. So I hope that answers your question. Melinda, the slide deck will be shared, right? Which has the timeline.
Yes, yes,
Okay.
we will get the slide deck posted here within the next day or so. And we will send out a notification when it has been posted. There was also another question posed regarding PACE. I heard on the call that the proposed launch date is 7/1/2026. Does that mean the program will go live on 7/1/2026, or with seniors being able to enroll then, or does it mean that the rules and regulations will be posted by 7/1/2026 and the program will launch later?
Kirsten, do you want to take that one? But I think it's fair to say everything is always depends on procurement and timeline.
Yeah, that's certainly our goal in terms of that timeline. As I just mentioned on that other answer, that we're trying to look at the fastest contracting vehicle for that vendor to assist us in developing that RFP for PACE. Certainly RFPs in our previous department might take 9 to 12 months. And so as Mr. Rich had mentioned, they're looking at trying to make some improvements to our procurement process in our new Nevada Health Authority. So I'm not sure how that procurement will look like, but certainly understand that many people are excited about PACE, and we will stand up the program as soon as possible within our resources and abilities that we have.
Thanks, Kirsten. I just have one more question. Yeah. About Bill 514 about RMH services. I'm not sure.
I don't know what that is. If anybody else does. But thank you, Sarah.
Hello, Sarah.
Yes, so I did just put in the chat. So this is in the initial phases of development. So Assembly Bill 514 is mental health rehabilitative residential services. I'm sure I switched up some of those words. But definitely development is underway, so expect a public workshop on this new model before we take it to public hearing at the end of the year. But definitely excited. This will serve as somewhat of a step down from our psychiatric residential treatment facility provider type, or a step up. It's really more so a community-based therapeutic group home-like model. So we'll be able to present more on that when we have more specific.
Perfect. Thank you. All right. One more question from Robert Moore. Go ahead, please.
Thank you. If an adult without children does not meet the work requirement in 2027, do they lose their Medicaid eligibility, or do they go to regular Medicaid at a lower FMAP and the state loses the 90-10 match on that enrollee? Thank you.
No, adults without children have to be employed or meet the definition of community engagement, which there are other options, like you can be in school. There are a couple other options. And we will do a full workshop around that, but I think it's all going to be in how we define some of the waivers around that, and making sure that we're not losing people that are slipping through the cracks that need treatment or don't quite have a diagnosis, right? Like a mental health or substance use issue that hasn't been treated. So, but no, they would be disenrolled or ineligible. So it's not like they get to move to a special category.
Thank you.
Yeah. We have one more. How is Nevada evaluating its state health information framework? Oh, Melinda, it's yours. HIE.
Let's see. What opportunities exist to strengthen HIE participation and interoperability? Oh, well, of course, we're always open to working with our HIE partners. So I would encourage you to reach out to me, and I'm happy to talk with you a little bit more about that and where we can plug in. So yeah.
And Natalie, I don't know. I'm sure DHS and Richard Whitley and that team is busy too. Like I'm sure that they will be having their regular updates, but I would reach out if you want more information then to maybe Director Whitley or Shannon Lentz and see if they have time and what they're planning. But, and we can also talk in the future about doing some joint updates, but those might be broader than this detailed one. And we plan to do this again toward the end of the year. So we like to do it kind of mid-year, so you guys know where we're at toward the end of the year, and then again early next year. So. Any other questions before we go?
I am not seeing any, and I did see that Kai just posted the link to the form to fill out feedback about today's presentation. So thank you, Kai, for doing that. And if you all wouldn't mind, it's really quick, I promise, just a couple of questions. It really helps us to improve this moving forward. So thank you all so much for your time today. I know it was a long one, but we were really excited to share all of these updates with you, and hope you found it very valuable. Thank you so much. Have a great rest of your day.
Thanks, everyone.
Thank you.